All righty, who'd like to go first this week? Brent, do you have cases? Looks like he's calling in. He's off-site, got it. Okay. David or Howard, do you want to start?
I've got some cases if you want me to start. All right. This one is particularly interesting. It's a new patient that we had a little while ago, actually just the other day. So this is a young person that has a radiograph that looks like this, and I'm withholding some information for the moment, but clearly he has bilateral diffuse multilobar opacities. In some locations, like magging up here a little bit, here, it almost looks like some of these are rounded as if we're seeing acini. And remember the term in the old days, acina rosettes or acina opacities, representing consolidation in portions of pulmonary lobules. But elsewhere, he certainly has consolidative opacities, mostly in the lower lung zones. And another thing that's relevant here, and I'll try to bring this out, is the presence of septal lines in the lungs as well. So for example, here and here, and there are some that I'll try to bring out in the perihilar regions, like there, maybe there. But I did believe I was also seeing septal lines as well. Now the heart size is normal, so we have this diffuse bilateral parenchymal opacity with septal lines. And certainly if the context is an acute febrile illness, which it turns out to be in part, then one should be concerned about obviously a pneumonia, but something other than an everyday community-acquired bacterial pneumonia. And with septal lines, one thing that I think of is hantavirus. That's described as having an appearance that may be like lung edema with septal lines. So he was very sick. You can see over here he gets intubated. Very sick, he gets to have veno-venous ECMO. And slowly over time the opacities get better, and now we see pleural fluid accumulation, some of which was drained. And sure enough, the only thing that was positive in his evaluation was for IgM and IgG. Here I'm showing IgM, hantavirus antibodies. So there is the history. Although they couldn't get a history of contact with rodents, mouse droppings, rat droppings, certainly the whole complex of findings and that micro result is certainly consistent with severe hantavirus pneumonia. So a really interesting case of that. And certainly the imaging findings are very consistent with that. I don't have a CT, but the chest radiographic findings are very consistent with that. Let me show you this one that's really interesting. This is a very complicated case, so just for the interest of time, I need to give you some background. So before we saw him, he had been treated at other hospitals. This goes back to November of last year. And he had abdominal disease. He also had some chest disease. Here you can see he's got some opacities in lungs with a right pleural effusion. It turned out that he eventually required surgery for, and it wasn't entirely clear to me, but small bowel pathology. And subsequently he developed intra-abdominal fluid and abscesses about distal small bowel. And what was found in his biopsy or the peritoneal fluid was mycobacterium. And he is an HIV positive patient. So he's got evidence of that infection. So to continue along, he's really sick. He's getting percutaneous drains and so on. And at some point in time, he gets his chest imaged. And his chest looks like this. So he's got innumerable small nodules. Some are definitely in the millet range or miliary nodules. Some are a little bit larger. And then subsequently, some of the pleural fluid cultured out tuberculosis as well. So I think it's very likely that this is disseminated mycobacterial infection in that context. And there is a statement here, as you can see from the notes here, that because the mycobacterium was found to be resistant to ethambutol, that was suggestive of maybe Mycobacterium bovis rather than just MTB. But here you can see the findings. So again, I think it's really likely that he had disseminated or developed disseminated tuberculosis with pulmonary involvement, as you see right there. Kind of an interesting evolution. And the pleural fluid also cultured out MTB, as you saw there.
So Howard, it was TB or was it bovis?
Well, I don't know if they ever made that distinction. Someone suggested based on this that it might be, but I couldn't find any place where they had cultured and actually characterized it as bovis. And I don't know if that's easy to do and separate it out from MTB in the usual way. I don't know.
But they said there was MTB, correct?
Oh yeah, here's a mesenteric lymph node with MTB, and you got it from the pleural fluid as well.
Okay.
Right here. Pleural fluid culture from November of last year, positive for MTB. Yeah.
Okay. Thank you.
Yeah, sure. This one is one we had just the other day, and it's a really nice teaching case. So this person had a radiograph in April. I'm not sure what symptoms he might have had at that time, but certainly the next one I'm going to show you, and I'll bring it up next door, is subtly abnormal. This was read as negative, but I think if we look at this radiograph on the right-hand side compared to the other one, and now I'll bring it up by itself, there are opacities in the lungs. They are multifocal, hard to describe, maybe just focal, subsegmental size. Some people might use the word ground glass opacity to describe that, but sometimes it's easier to perceive that something is wrong or present rather than easy to describe it. So that is on the 12th, and I will show you early July. Certainly here you can see now he has a diffuse process. So it was present before, but very abnormal at this point in time. So now we have confluent polymarginate opacities throughout the lungs. And here I will show you what the CT looks like. And this is on the same day. So now we see what it is. So it's just multifocal, multilobar, confluent geographic ground glass opacities, a little asymmetric, except for one single little cavity right there. And that's the only nodule, circumscribed nodule that I could find, but it's a cavity. And then I noticed that he was lymphopenic. And in summary, this is a patient who was then diagnosed with AIDS. Here you can see a lesion that they were concerned about, Kaposi sarcoma. Yes, he does have pneumocystis. And interestingly, he had symptoms or signs of a meningitis. And here is a Cryptococcus antigen from serum, and I think there may have been one from CSF2 that was positive. So based on that, he also has Cryptococcus. I can't recall seeing one solitary cavitated nodule as a manifestation of Cryptococcus. I don't know if you folks have. Is that something? I wouldn't ordinarily consider that, as opposed to multiple circumscribed nodules. So I'm not quite sure what to make of that right there. But otherwise, they are treating him, of course, for both the pneumocystis and for Cryptococcus, and he's got cerebral lesions, on MRI right there. So I don't know if this is Cryptococcus. I think it would be odd, but I don't know what else it might be. Unless he's got another fungus that just never showed up or was not diagnosed. So infection is a theme. The last one I'll show you is kind of interesting. So the context here is this unfortunate patient with SLE and pulmonary hemorrhage. Here you can see she's very ill. She's intubated. She's got diffuse lung opacities consistent with diffuse severe pulmonary hemorrhage. and I will show you a CT done about a week later, in which we see all those opacities, certainly consistent with hemorrhage, and a finding that could easily be overlooked amidst all that in one location is this right there. So here's an area of cavitation in that right lower lobe. And I'll give you some more information in a moment, but for comparison with this one, I'm going to show you a CT that was done. So she was discharged, the diagnosis was made, she was treated, but she came back ill again. So this is a separate admission the next month, but only a couple weeks later. And at this time on the right-hand side, you can see she's got cavitary lesions in the lower lobes. There's the one I showed you before. There are others. And then there's this one here too in the left lower lobe with kind of an Eric crescent sign. So certainly this is consistent with invasive fungal infection. And supportive evidence for that is on the previous admission. They did get Aspergillus fumigatus from a BAL. And you can see also that she has a positive beta-2 glycan in March. So putting everything together, she certainly has findings consistent with opportunistic Aspergillus infection on top of her diffuse pulmonary hemorrhage, producing these cavitary lesions otherwise obscured by all that pulmonary hemorrhage that you see there. So kind of an interesting presentation of that. All right, Jeff, I can show more if time permits, but those are mine for now.
Okay, thank you, Howard. David, do you have any cases?
I can show a case here,
Okay.
and maybe the second one. So here is a 27-year-old woman who at this time in 2012 presented with fever and night sweats and had a diagnosis of tuberculosis made. So this is acute tuberculosis in the right upper lobe. And you can see that there's maybe some pleural involvement down here, some pleural stripe there that seems to be fat, stuff like that. And she was treated. And so a few months later, this is what her radiograph looked like. The right upper lobe consolidation has regressed somewhat, but we're left with a granuloma down there, and then we have this quiescent-looking pleural process down here. So fast forward to, let me bring up the current imaging here. So let's go to the current chest radiograph, and here she is with, now she has chest wall pain on the right. So her right upper lobe nodule, looking like a granuloma, hasn't changed very much in these few years. It might have shrunk down a little bit. But we still have this pleural thing here. Maybe it look a little fat, maybe it looks a little fatter than before. Plus we have this swelling in the chest wall that wasn't there before. So she was CT'd because of this mass in her chest wall, and lo and behold, she has this fluid collection in her chest wall. Let me shrink this down a little bit. So you can see that there is a pleural abnormality here. It seems continuous and contiguous with this chest wall lesion here. So they tried to do a percutaneous needle drainage of this fluid collection, and it was unrevealing, so she eventually had incision and drainage. They scraped the inside of this lesion here, placed some drains, and then PCR identified Mycobacterium tuberculosis. So here's a case of latent TB that sprang back to life. Probably this pleural focus here adjacent to it broke down, and organisms got, you know, farther in the pleural space and then into the chest wall. So this is spread of TB with this chest wall abscess. People were busy calling this empyema necessitans, which I think is a misnomer. So that should mean an actively draining focus. It's possible that this chest wall fluid collection would have fistulized and drained from the skin, at which point it would be a necessitans, but it's not really empyema as much as it is a chest wall abscess necessitans that was future, not current. So Rachel Edwards showed me this case. She was our fellow last year, and she's now joined the faculty at Harborview, spends half her time on trauma radiology and half on chest. So she saw this as part of her trauma assessment of CTs. I guess this person, CT came through around the time she was on. And she showed another case that was almost identical findings from the same era. Again, a young woman who developed a chest wall fluid collection like this, and it was shown to be tuberculosis on the basis of PCR. So this is not the only case we've seen of this. Then Julie Takasugi from the VA had shown me a case years ago of a subpectoral late tuberculosis finding of fluctuant mass under the pectoral muscle on the right, and that was also a recurrence of TB from adjacent pleural focus. So this happens. This is the third case I've seen of this phenomenon. So let me show you this this other case now. This is a person who had leukemia. This is an AML, and it's what they used to call an M5 form of leukemia, which means that it has a big monocytic component to it. So they have rearranged the way they describe these leukemias. The AMLs used to be numbered. I think 5 was the highest number. So this corresponds to that, but they now describe this in terms of the genetic rearrangement. But there was diffuse lung disease and some shortness of breath in this, and the person had this CT scan, which shows, as Howard was showing earlier, lots of septal lines. So we can see septal lines here in the apices. I'm sorry about all the motion artifact. And this sort of smudginess throughout the lungs, maybe some central lobular opacities here and there, and then lots of atelectasis, and this coarse lung consolidation in the bases here. Again, lots of septal lines. So it's pretty nondescript, finding the person was not volume up, and this, so we didn't have a good reason for all of these septal lines, and the shortness of breath was out of proportion to the amount of lung disease that we're seeing here on this CT scan. So the person did not do well and died, and then went to autopsy. The autopsy was presented last week to the medicine team, and the lungs were full of leukemia cells. So this is what we used to call chloroma, meaning that the cells are not circulating in the bloodstream, but they're actually in tissue. It's also called granulocytic sarcoma, or in this case, myeloid sarcoma, because these monocytes, or myelogenous cells here, were infiltrating the tissues widespread, and they were all over the body. Actually, they were in the brain and in the kidneys as well. So the septal lines, in particular, contain large numbers of these monocytic leukemia cells. So the tissue infiltration particularly goes with the monocyte component, and this person's leukemia was, specifically mostly monocytes, and here they are in tissue throughout. So the CT scan actually corresponded quite well to the findings at autopsy in terms of septal lines and so forth. I'm trying to get the some gross pictures from the autopsy. If I can get those by next week, I will show them as follow-up to this case. So what looked like edema here was actually infiltration by these monocytic cells of the lung interstitium. Those are the two I have.
Yeah, that's a remarkable case. That's really interesting. Yeah, if you could ever get slides, I'd love to see them, because
it's said that that leukemia is frequently present at autopsy in the lung, but it's seldom visible or seldom recognized. And this is where we did actually have some findings of it ahead of time. Didn't understand what they meant, though.
Yeah, I'd like to see if there were if the leukemic cells were in venules and lymphatics and the septa, all of the above, maybe. Who knows? Yeah, it'd be lovely to see it.
I'll try to mobilize that.
Yeah, thank you.
All right, thanks, David. All right. I can show a few here. All right, so you should see a chest radiograph. Everybody see my screen?
Very good.
Okay, so this is a young woman who presented with chest pain. And you can see there's a peripheral wedge-shaped area of consolidation here in the
If
right
so
lobe.
far I just see your database screen, I haven't seen the image yet come up.
Oh, okay. I know how to fix that. It's, sorry, because
Oh,
it's
maybe it's showing on another panel.
try that.
Yes,
There
there
we
you
go.
go.
Okay. So young woman presents with with chest pain, has this peripheral wedge-shaped area of consolidation, very small pleural effusion. And so obviously with that history, you'd wonder about a pulmonary infarct, could be developing infection, something like that. She did have a CT angio at the time, and this is about 3 years ago. And what we see, actually a couple of findings. First, we see some hilar lymphadenopathy on the right. And then we have this area of consolidation with central low attenuation that looks like a pulmonary infarct, but there's a little separate area of nodularity next to it. Interestingly, if you follow the pulmonary arteries, it's very peripheral. It's hard to find any thrombus going to that area necessarily. So it's possible it was very small or it's already lysed, but hard to see a thrombus. But the other finding of interest is in the right lower lobe. I think I went too low. Yeah, is this dominant nodule in the superior segment, and then there's all these little satellite nodules, and you can see them sort of along this vessel here, like kind of along the lymphatics around this. So you got a dominant nodule with a bunch of little satellites around it. So, this appearance for us is very typical of granulomatous infection, particularly histoplasmosis. I've seen cocci look like this as well, but this dominant nodule with all these little things here. But this second lesion in the right upper lobe looks more like a pulmonary infarct. So that was 2013. Here she is about 2 years later. And you will see that this upper lobe process has pretty much scarred down. There's a little bit of thickening around the vein there. But this lesion here in the right lower lobe, the nodule is still there, and those small satellites are still there. And you can see it's starting to get denser. So it's starting to develop some calcium. And we now see some subtle calcium in the hilar nodes here in the right hilum. And then the final scan I have is 2016 here. And so at this point, you see this nodule has become thoroughly calcified, as have the hilar lymph nodes. And there's denser peripheral calcification, there's some faint central calcification. And interestingly, in that area, what looked like an infarct is still sort of that irregularity there. So it may be scar from an infarct or just something else. But this is a very classic evolution of histoplasmosis, where you get this dominant nodule, the satellites, and then over time, and it can take years, it starts to calcify. And I know David's going to ask me about the spleen, which she did not have any calcifications in her spleen. But this was proven by urinary antigens, which is kind of how we prove this. So this is just sort of acute histoplasmosis, and whether that infarct was related or not, because we never could find a pulmonary embolism, is unclear to me. But it's unusual to get a pleural effusion with histo, so I suspect that was related to the infarct, the one we saw in the radiograph, that little bitty effusion there. So yes, and it's interesting because we end up following a lot of these nodules, at least until they get referred to us, but recognizing this pattern of this dominant nodule with all the little satellites, usually around the lymphatics. Like if you look at this vein here, for example, you can see it's kind of beaded, and those are little granulomas or granulomatous lesions, and kind of along the airways too. So it gets both venous and arterial. Pretty specific, and I'm sure David and Howard, you've seen this with cocci, can sometimes do this as well.
Yeah, I think so. Yeah.
Okay. This is a great case here. This is a fun one here. So this is a woman who works, and let me see, make sure I'm showing the right screen here. So you should be seeing now a CT scan.
Okay.
So this woman works in a door manufacturing plant where she's exposed to plastics and aluminum. And she presented with a chronic progressive cough that was interfering with her work and annoying her coworkers. So I don't have her radiographs, unfortunately. This was an outside scan. And this is the right one here. But it was abnormal, so they did a CT scan. And you can see she has this extensive crazy paving, so septal lines, ground glass opacity, a few areas of spared lung, and then a slightly more confluent, maybe small focus of consolidation in the left lower lobe. She wasn't febrile or anything, so there was no concern of superimposed infection. Unfortunately, they, at the outside institution, decided to do a surgical biopsy instead of a BAL, and this was a proven alveolar proteinosis. Now, what's really cool is this is her follow-up 6 months later. And you can see she's gotten a lot better. Not all the way, but there's definitely an improvement. I'll put them up next to each other. And let's see, move that up here a little bit. But let's see. I think that's how you do it. There we go. Yeah. All right, so you can see she's gotten a lot better. Now the question is well, what did they do? And the answer is they didn't do a BAL, which is the treatment. A whole lung lavage is the treatment of choice. They did not give her GM-CSF. They told her to stay home from work and put her on workers' comp, and this is spontaneously resolving. So this is the only thing that she's exposed to that has been reported to cause alveolar proteinosis is aluminum dust. So this is presumptive aluminum-induced alveolar proteinosis, and the diagnosis is being based on the fact that when she was no longer exposed to aluminum, it started getting better. So there are some case reports of aluminum-induced alveolar proteinosis. I don't know if anybody else has ever seen this before. I have shown you a case that responded to GM-CSF and resolved, and other cases where they get better with BAL. But yeah, this is the first I've seen.
Jeff, was there high density material in her nodes at all? Does she have some metal in her nodes?
You know, I was wondering the same thing, and the answer is not really, no. Here's the soft tissue from the outside one. And you can see she has just normal looking nodes. I didn't think they were particularly dense.
Speaking of aluminum, her employers could have canned her. Get it?
Gosh, ouch. Yes, so aluminum dust. I've seen, the only other case of aluminum-induced lung disease I've ever seen was just the dense lymph nodes from the dust. It usually doesn't cause, but you know, this is probably an immunologic reaction, I suspect, and that's maybe why he doesn't require a large burden of dust. Okay, and then this is an interesting case I saw this weekend. Let me bring up the radiograph here, show you. So this is a patient who presented with sort of some vague back pain. And you know, the history changed depending on which body part they were imaging. But the bottom line is he was having some back pain. And you can see this, the PA radiograph is abnormal. There's right paratracheal stripe thickening. There's fullness in the upper mediastinum. And then there's a mass or something, a mass-like area in the left lower lobe. You see some of the descending aorta, but this sharp thing. On the lateral, you can see this mass well circumscribed here. It's lifted off the diaphragm. It's not associated with the stomach. So it looks like a true mass. And you don't see much of hilar lymphadenopathy. So there was concern there's a lung cancer or some other malignancy. But the patient was having, because of this back pain, they decided to do a chest, abdomen, pelvis aortic study. And you can see as we look here, there's tumor. Change the window. There's all this lymphadenopathy in the mediastinum, kind of confluent. The cava is narrowed, some down in the lower mediastinum as well. And then left hilar region, there's narrowing of the airway. There's a mass protruding here. And then inferiorly, we see the mass we saw on the radiograph. So it looks like a metastatic lung cancer, pericardial effusion, and a small pleural effusion. But this patient was having, again, this vague back pain. And so looking at the rest, so now we're in the abdomen phase, you'll see the image noise changed. And what was found was there's this necrotic mesenteric node here. And further down in that region, we see some other mesenteric nodes that are all large and necrotic. There's atheroma, but no acute aortic pathology. And then further down, the small bowel here looks very unhappy. There's some fluid here, there's wall thickening, and then there's some extraluminal gas. So there's what looks like a contained perforation or a very small perforation, and probably a little defect right here in the small bowel wall. And then this lytic lesion in the iliac crest here. So clearly we have a metastatic malignancy and either a second pathology or one related. But the fact we've got these unhappy mesenteric lymph nodes, and this looks like a small bowel perf. So they opted to take this guy to the operating room. One of our abdominal radiologists reviewed this with the surgeons and agreed, and pointed this out to them. And told them that, this is a small bowel perf and it's probably from tumor. And the surgeons were, I think, leaning more towards lymphoma, but it didn't fit with the chest finding. So they took this patient to the OR, and there was a small bowel perf, and there was tumor infiltrating the wall. And so the pathology on this tumor here, the small bowel, was squamous cell carcinoma. So this is a lung cancer that presented with this small bowel perforation. Now the back pain, I don't know, it may have been a vague abdominal back pain. I'm sure this was contributing to some of the pain as well. But kind of an interesting presentation, not aortic disease. So I think they were a little surprised to find this, but patient presenting with this radiograph. So squamous cell carcinoma. I've got some from last week I can show as well. Let me show you this one. This is just a pretty one that Daniela showed me from her weekend a couple of weeks ago. This patient presented with chest pain, and this was the CT angio for pulmonary embolism, and there's no PE. But you see this. Oh, I'm sorry. Every time I switch, I forgot I got to switch back. There we go. All right, so here's the CT, and we see there's this nice sizable pericardial effusion here. And this patient had sort of a viral prodrome, and they tapped this effusion, and it had lymphocytes and stuff in it. And so this was a viral pericarditis that responded to conservative therapy. Developed some pleural effusions, probably because there's a little bit of left heart dysfunction because of this pericardial effusion. It wasn't frank tamponade, but you can see the IVC is large, and the SVC is pretty big, and the ventricles aren't particularly filling that well. So maybe early tamponade. So that was one case.
Jeff, the people around here have made the point that when you have pericardial inflammation, you often get a accompanying left pleural effusion.
Why is that?
And it's a helpful finding, because if you see what looks like a large heart, but instead of having a predominant right pleural effusion, it's predominant left, pushes you away from heart failure, because heart failure, it's almost always larger on the right than the left, but does point you in the direction of pericardial inflammation. I've seen that be very helpful in a number of cases. So for some reason, I don't know whether there's a big surface of pericardium in the left hemithorax, and anything that's inflamed there spreads the inflammation to the pleura. I mean, that's, it may just be its contiguity that does it. But that's actually held up quite well, and your case is another example.
Yes, absolutely. There's a smaller right than left effusion. Okay, well, let me show the other case of pericarditis and see if that holds out true. This one has a radiograph. Hold on, I'm going to switch and show the screen here. So Daniela had the same case, I think, or the second case in the same weekend or same day. I can't remember, but yeah, back to back. So maybe there's something going around. But this patient has what looks like a large heart. If you look on the lateral, it's not, maybe in retrospect there's a little stripe there, but it's a lousy lateral, too much motion. So CT shows pericardial effusion. This one's nice. You can see a little bit of pericardial enhancement, and not so much squeezing here. So but it's more well defined than that last case. And there's the left effusion, David. 2 for 2. Well, that's an interesting fact. I wonder. I like your idea maybe of the surface area. That's a pretty sizable area. You do have almost as much on the right. It may have something to do with lymphatic drainage as well.
Yeah.
So, and then you get the sort of the adjacent lymph nodes are swollen. This is another case of presumed viral pericarditis, which is usually the most common cause.
Summer is supposed to be the Coxsackie pericarditis season.
Yeah, and that's true. I'm not sure if we see a lot of Coxsackie out here, but it's probably everywhere. We get the West Nile and some of those too in the summer.
Wow.
Okay.
Jeff, I have 2 more occupational cases, or 3 occupational cases I could show you.
Good, because that was my last one. All right, let's see.
Okay, can people see an old-fashioned filmed CT that has been scanned?
Yes, and it looks like they did it to save film. They got it all in the one sheet.
That's right. So small pictures. These are cases. I'll show you 3 cases from a visiting Persian radiologist who brought these for our teaching case, and these are all occupational. So this person was a sheep herder, And you can see on the scout view that there's a smooth, round lesion in the right base. In the bottom, second to the bottom row, we can see this fluid-filled lesion adjacent to the diaphragm and liver, and nothing that remarkable about the internal characteristics. It does have a little bit of thickening of the wall, but I don't see any membranes floating in there. But this is hydatid disease from sheep herding. So that's one occupational case. And let me see if I can bring up these others here. And then here are two coal miners from Iran with extensive distortion here in upper lung. So this is complicated silicosis. I have this image is reversed. Let me flip it around for you here. But these lymph nodes, including calcified eggshell nodes in the neck as well. So this is the first time I've seen them spread this far away. And I guess these are hilar. Probably the hilar structures are being pulled out into the lung by the extreme degree of distortion here in this advanced silicosis from coal mining. But I just wonder if there are nodes in the lung as well, beyond the hilar nodes being pulled out, that share this eggshell pattern. And the other case, there's a third case of, I'm having trouble advancing this here. Okay, well, there's another case that is very similar in terms of being a coal worker with lots of distortion and calcified lymph nodes, but not as many in the regular neck.
David, why are you calling this silicosis and not coal worker's pneumoconiosis, since he worked in a coal mine?
Just because, well, I mean, I can't say for sure, but it's the degree of distortion here and scarring that I think favors silica exposure over just coal dust. So coal dust is not as fibrogenic, at least in the reading that I've done. And so when you get extreme distortion like this, I think that is probably more reflective of silica and the intense scarring that it engenders as opposed to.
Right. I guess I would make the argument there may be silica mixed in with a lot of coal dust, as we know, because it's mixed rock, quartz, and stuff. But now, just from a terminology standpoint, I mean, I would call it coal. If it's a coal miner, I'd call it coal workers pneumoconiosis, and it looks the same.
Yeah. Okay.
Very interesting. Wow.
So people are better off staying home a lot of the times. You should avoid your work in the aluminum place, and definitely stay out of coal mines. Don't do sandblasting, and avoid sheep.